So next we're going to do some techniques for correction of pelvic asymmetries. First we're going to start with SI joint rotation, so either an anterior rotation of the ilium or a posterior rotation of the ilium, and different ways to fix that. So there's muscle energy techniques and there's manipulations, and then on top of that there's a couple other things in between or a mixture of the two. So we're going to start with the manipulations and then we'll go into muscle energy techniques for the SI joint. So, sorry, I coughed. So we're going to start with our patient in side lying, as you see here. And first we're going to focus on correcting an anterior rotation. So in order to correct an anteriorly rotated ilium, we want to bring it posteriorly. So the way we're going to do this is we're going to get under our patient's leg and kind of get it almost over your shoulder in a way. So in this case, you can also bring the table up a little bit more. We can't adjust our table, so I just have to squat. So I'm going to use my forearm on her ischial tuberosity to create that inferiorly directed force, and then I'm going to use my other hand on the ASIS to get that posteriorly directed force to create that rotation moment on the pelvis. So what that's look like is something like this. In addition to this, you can also, to lock out the patient's spine, you can have them reach around the table so you can get the rotation in their upper body, so that way they're not having that impacted by the manipulation of their pelvis. So from here, get the slack, and then press. So that's for an anteriorly rotated pelvis, correcting it to go more posteriorly. The alternative to that would be to bring their leg around you, onto your hip, like so. So this is also a form of a muscle energy technique where they can directly contract their hamstrings, so push into me. So that contraction of the hamstrings can also create that posterior rotation, but in this case, we're going to use it to facilitate an anterior rotation. So in this case, I'm going to be pushing superiorly on the ischial tuberosity and pulling anteriorly and inferiorly on like the ASIS and the iliac crest to induce an anterior rotation to correct a posterior rotation. So keep our patient's upper body rotated. Let's kind of lock them out here. And then go for it. So those are manipulations for posterior and anterior with that muscle energy technique. You can also do some stuff in prone, so if you want to go prone. There's two different techniques you can do here. You can do muscle energy techniques here as well as manipulations or a combination of the two. So when you're using muscle energy techniques for rotations of the pelvis, to create an anterior rotation, you're using the iliopsoas to pull that pelvis anteriorly, or if you want to get more posterior rotation, you're using the hamstrings to bring that pelvis back. So you can use that to your advantage in prone. So if she's posteriorly rotated and I want to get her more anteriorly rotated to where she was, I can pick up her knee and I can have her just contract into my hand, activating her rectus femoris and iliopsoas. And in addition to this, I can provide an anteriorly directed force, and I can also do a thrust here as well. In addition to that, I can also create that rotational moment like we did before in the upper body. If I move the camera slightly, so if you get into a push-up like position, like you're going to push up, but then push up only with this, your left arm? Yeah. With your left arm. Can't tell you, right from the left. So push up with your left arm, and then you can provide that anteriorly directed force onto that same side of the pelvis as well to correct that posterior rotation. In addition to that, you can also have a patient in supine. Flipping all over today. So if you have your patient in hook lying, you can also use pressures through the knee on either side to use those muscle energy techniques with the rectus femoris and the hamstrings to correct either an anterior or posterior rotation. So if you push into my hand here, activating that rectus femoris, pulling that pelvis more anteriorly, or push into my hand here, activating the hamstrings to pull it posteriorly. In addition to this, another muscle energy technique that you can do, which is most commonly done at the beginning, is the shotgun technique. So also in hook line here, you have their feet a little bit far apart, and then you're providing a adduction force and having them resist into adduction, holding that for 10 seconds. You can also do a spring at the end, and then providing an abduction force for 10 seconds. You all right there, Katie? All right, so this can help reset the pelvis. It can also be a provocation test for pubic symphysis dysfunction as well. So this could be painful for some patients, but it is very commonly done as a corrective technique. From there, let's see here. I think that's about everything. Oh, one last thing. In the case of the rotation might not just be ipsilateral, it might, or unilateral. It could also be bilateral, so one could be anteriorly rotated and the other could be posteriorly rotated. So in that case, you can use a broom. So if I take the broom through here, she can hold on to the broom herself and contract her hamstrings on one side and rectus on the other, creating that force at the same time to correct both of those sides. So that's an at-home technique that can be used as well. So next we have some mobilizations of the sacrum specifically for nutation and counter-nutation and some ways to do it at home. So we have our patient on the edge of the bed. We have them holding on, make sure that they have shoes on for this so they don't go sliding on the floor. So you're going to be inducing nutation by taking the palm of your hand at the top of their sacrum and pushing anteriorly. You can do graded mobilizations here, 1 through 4. And then you can also go lower on the lower sacrum and induce counter nutation, or in the direction of the force, because that's good. In order to recreate this at home, you can have patients get a towel just like this, and then have them lay supine. So they can do this, if they're having pain in the middle of the day, just have this towel sitting around and lay on it for pain relief to kind of get it reset back to where it needs to be. So they can lay on that for a few minutes or until their pain is relieved. And then if you want to sit back up again, you can do it lower to induce that counter nutation. And if for some reason the patient doesn't like to be supine, they can also do the same exact thing in sitting with those towels in basically the same position. So you can have them sitting on a chair like this, sitting that towel at the top of their sacrum, and having them lean back. They can do this while they're eating dinner, and then have it lower in the same way. So from here, another common intervention for SI joint pain or pubic symphysis pain is to use an SI belt. We don't have an SI belt here, so we'll just demonstrate how it works with a gate belt. So the SI belt can be applied in 2 different places. It can either be around the ASISs and the PSISs in the back to provide the compression and tactile cueing for stability for SI joint hypermobility. So it can be here at the ASISs and the PSISs in the back. I'll pay for that. Or it can be a little bit lower over, be a little bit lower over the pubic tubercles, and then create the compressive force there. And they would wear this as much as possible Ideally wear it for everything but showering, and ideally it would also be directly on the skin. Obviously I'm not going to demonstrate that because I don't want to reveal Katie to the entirety of YouTube. So that would generally be frowned upon. And that's about that for techniques for correction of pelvic asymmetries. An additional technique for bonus points is using the piriformis to address sacral tilts. So instead of nutation or counter nutation of the sacrum, it can also tilt side to side. So since the piriformis attaches to the sacrum, you can actually use a muscle energy technique of the piriformis to correct that tilt. So in this case, we have our patient against a wall, and they're going to use their hips and their knees, basically the side of their leg, like IT band area, to push into that wall, creating an isometric external rotation, contraction, getting that piriformis contracted and shortening. So that'll be pulling on the sacrum, creating that tilt as to where you need the tilt to be. You can also do this at multiple points in the range of motion. So she's turning more into internal rotation, creating a bigger pull by putting that piriformis on length to begin with for the isometric contraction. So that's that for piriformis. So next we have exercise prescription for lumbopelvic dysfunction. So as a general rule, after we've done our muscle energy techniques or manipulations to correct the rotational or nutational issues within the sacrum or the ilium, causing that lumbopelvic dysfunction, you're going to want to stabilize. So there's the lumbopelvic stabilization program that's discussed within Olson. So there's 3 different phases. Phase 1 focuses on isolation of the transversus abdominis in that neutral position. So we're going to do a couple exercises from phase 1 to focus on that. So here we're going to be in hook line and practicing that draw-in maneuver that we did in our assessment. So same thing as before, we're having them practice palpating on one side, we're palpating on the other, getting that draw-in contraction by having them pull in towards the table, and then we're going to practice the marching like we did before with one leg up and one leg down. From here, what you can do is have them slowly extend their leg and then bring it back up into hook line as well. The next progression from here, once they get good at that, would be to extend their leg down, maintaining that TRA contraction, and then doing a leg lift. So like an active strict leg raise, and bringing it up and then back down. And then same thing on the other side. So that's phase 1. And then for phase 2, we're talking about building stability of the neutral spine position while challenging the patient in multiple positions with other extremity motions. So this is using, if we go back to our physics, we're using increasing the lever arm away from the actual muscle that's being activated to induce more movement and challenge the dynamic stability of the spine. So here, we're going to have our patient sideline, turn towards me, and then we're going to have them practice that TRA contraction again, but they're going to be doing hip abduction of the top leg. So you're going to straighten that top leg and then abduct. So contract and then bring it up and then down. So making sure they're contracting their TRA the entire time. Go up and down. That's the idea there. From here, we can have our patient in standing. I'll probably have to adjust the camera. Yeah. So, for this one, we're increasing the lever arm even further. First, we use the lower extremities. Now we're going to use the upper extremities. So from here, you're going to hold on to both ends here. And then you're going to straighten out your arms on either side. Straighten out. And then you're going to be coming from shoulder flexion to shoulder extension. And you can do one arm at a time as well to create that rotational challenge on the spine, challenging not only the transversus abdominis, but the multifidus as well in the back with that rotational component. So you're trying to make sure that their back and their torso are staying straight and that they're contracting their TRA the whole time. So you don't want to see them rotating their core or anything like that. From here, you can also have them in quadruped and practice just maintaining that quadruped position and then progressing to bird dogs from there in phase 2. From here in phase 3, we're looking at more dynamic mobility of the spine. So instead of just maintaining that neutral position, now we're challenging them even further. So from here, ideally in a clinical setting, we would use a weighted box, but since we are physical therapy students, we have textbooks. So here we're focusing on squatting down and picking up that textbook while maintaining that core control and stability here. We'll give that a go. So just squat down, picking up, beautiful, and then lowering it down. So you can work on those as well as doing sit to stands as well. So just sitting at the edge of the bed and doing sit to stands and maintaining that core control throughout the motion. So that's the lumbo-pelvic stabilization program. In a nutshell, there's plenty more exercises. We just did a couple of them here today. So next we have exercise prescription for pre or postnatal status. So thoracic mobility can be negatively impacted during pregnancy, as there's often an increased thoracic kyphosis due to the weight shifting and center of gravity changes during pregnancy, in addition to changes in rib mobility and increased rib flare with the hyperventilation that many patients often deal with throughout pregnancy. So for this, we can use a foam roller at home to increase that thoracic mobility. So on top of doing thoracic manipulations and joint mobilizations in clinic, we can also use a foam roller to do the job for us. So in this case, we have our foam roller perpendicular to the patient, and they're going to lay back into supine with that foam roller over their thoracic spine. Then they're going to grab behind their neck, behind your neck or your head, whatever works, whatever's comfortable for the patient. And they're creating a little bit of cervical flexion. And then to increase the weight bearing on that thoracic spine, to induce that mobility and use the foam roller to its best advantage, you're going to have them do a glute bridge. So that's inducing the force is from below and above into that foam roller, and then they can roll up and down, and you'll often see that many patients, they'll crack on their own, and they'll get that grade 5 mobilization just from the foam roller. So they can do this to increase mobility of the ribs and the thoracic spine, and depending on how much of a glute bridge they have and how much cervical flexion they have, they can kind of grade how the intensity of this particular mobilization. From here, if you want to sit, we can also adjust the foam roller to go parallel to the patient and have them sit over it. And you'll also find with the thoracic kyphosis, often their shoulders will be internally rotated and they'll start to develop that hunchback type posture, so their pecs will be very tight. So in order to fix this, you can have them laying over a foam roller, and honestly, many patients just sitting here and having those shoulders back and protracted is enough. But on top of that, you can have them come out to 90 and lay back like this to get a really nice pec stretch at home. Patients love this one.